This EEG tracing captures an ominous neurophysiological phenomenon known as alpha coma. It represents a severe discrepancy between a patient's clinical state, deep, unreactive coma, and their electrographic background, which superficially resembles a normal, awake rhythm. 1. Identifying the montage, referential recording. Unlike the previous cases which used longitudinal bipolar setups, this trace utilizes a referential montage, indicated by the A1 and A2 tags. Odd-numbered electrodes from the left hemisphere are referenced to the left earlobe, A1. Even-numbered electrodes from the right hemisphere are referenced to the right earlobe, A2. 2. Neurophysiological features of alpha coma. While an alpha rhythm, 8, text to 13, text HZ, is normally the hallmark of an awake, relaxed individual with closed eyes, the alpha, seen in this comatose patient possesses crucial pathological distinctions. Frontal dominance. In a healthy, awake individual, the normal alpha rhythm is a posterior dominant rhythm, meaning it is highest in amplitude over the parietal and occipital regions, O1, O2. In this tracing, the alpha range activity is widespread but maximal over the frontocentral regions, seen clearly in F3, F4, C3, C4. Monotonous and unreactive rhythm. Normal alpha waves are highly reactive. They attenuate, block, immediately when the patient opens their eyes or processes sensory stimuli. In an alpha coma, this rhythm is completely unreactive to external auditory, tactile, or painful stimuli. Underlying delta activity. The alpha range oscillations are superimposed on an underlying background of low voltage, arrhythmic delta frequencies, indicating profound, widespread cortical dysfunction. 3. Clinical context and pathophysiology. As documented in the figure caption, this 34-year-old patient suffered severe hypoxic ischemic brain damage, HIBD, secondary to a subarachnoid hemorrhage complicated by diffuse cerebral vasospasm. The mechanism. Alpha coma typically occurs following catastrophic neurological insults, most frequently cardiopulmonary arrest, anoxic brain injury, or severe brainstem lesions, such as pontine hemorrhages. The circuit disruption. The physiological generator of normal alpha depends on intact, bidirectional pacing between the thalamus and the cortex. In anoxic alpha coma, severe diffuse cortical necrosis effectively uncouples the cortex from lower pacemakers, or a brainstem lesion cuts off ascending reticular activating system, ARIS, inputs. The remaining thalamocortical networks enter a continuous, unreactive, monotonous loop at an alpha frequency. 4. Prognostic significance. In the setting of acute hypoxic ischemic encephalopathy, the appearance of an alpha coma pattern is a poor prognostic indicator, strongly correlating with severe irreversible neurological deficit, persistent vegetative state, or brain death.
Imagine you are looking at the EEG of a patient who has suffered a severe brain injury, such as a lack of oxygen after a cardiac arrest. What you are seeing here is a textbook burst suppression pattern, which is a sign of a profound, critical shutdown of global brain function. If you look closely at the tracing, you'll see it is split into two distinct, alternating phases. First, there are the bursts. These are sudden, high-voltage clusters of electrical activity made up of sharp waves, spikes, and slow rhythms that fire simultaneously across almost all the LEDs. Immediately following these bursts, the brain's electrical activity completely plummets into suppression, which are periods of flatline or near total silence where the voltage drops below 10 μ, text, V. Mechanistically, this happens because the brain has been starved of oxygen and has drastically depleted its cellular energy stores. The normal, smooth communication networks between the deeper brain structures and the cortex have broken down. Instead, the damaged cortex fires in brief, hypersynchronized gasps of energy, followed immediately by periods of metabolic exhaustion. As a clinician, seeing a persistent burst suppression pattern in a comatose patient, provided they aren't heavily sedated on medications like propofol or barbiturates, is an ominous sign. It tells us that there is widespread, typically irreversible cortical damage, and unfortunately, it carries a very poor prognosis for neurological recovery. When evaluating a patient with severe hypoxic ischemic encephalopathy post-cardiac arrest, identifying specific electrographic signatures is vital for neuroprognostication. This specific tracing demonstrates a classic generalized periodic pattern, specifically characterized by generalized periodic discharges, GPDs. On visual inspection, You will note stereotyped, generalized sharp and slow wave complexes occurring rhythmically and synchronously across all channels at a regular interval of approximately 1 text Hz. The intervening background activity is profoundly suppressed and lacks normal voltage gradients or reactive transients, indicating a severe, diffuse disruption of cortical-subcortical networks and profound metabolic failure. A critical confounding variable to note in this clinical scenario is that the patient presented with severe bilateral myoclonus, highly suggestive of post-anoxic myoclonic status epilepticus, and was chemically paralyzed with pancuronium to suppress the physical movements. In the ICU setting, neuromuscular blockade is frequently necessary in these patients to eliminate massive myogenic and movement artifacts that would otherwise obscure the recording, thereby allowing a clean, uninhibited assessment of the underlying cerebral architecture. From a neuroprognostic standpoint, when these generalized periodic discharges are encountered on a highly suppressed background in a comatose patient following a cardiac arrest, they represent irreversible, widespread neocortical injury. In accordance with current multimodal prognostication guidelines, this malignant EEG feature carries an exceptionally poor prognosis for meaningful neurological recovery. When evaluating a patient with rapidly progressive neurodegenerative decline, recognizing the specific electrographic signatures of spongiform encephalopathies is crucial for narrowing the differential diagnosis. The tracing in image_DDE0 Phaylink to .png demonstrates the classic diagnostic hallmark of periodic sharp wave complexes, PSWCs, in an average reference montage, captured here in a 67-year-old female with Creutzfeldt-Jakob disease, CJD. On visual analysis, the tracing is characterized by generalized, bisynchronous, and symmetric diphasic sharp wave complexes. These stereotyped waveforms recur rhythmically and predictably at a periodic frequency of approximately 1.5 text to 2.0 text Hz. Between these complexes, you will note a profound degradation of the normal background architecture, which demonstrates diffuse, low-voltage slowing with a complete loss of normal alpha rhythms and reactive transients. Pathophysiologically, the emergence of PSWCs correlates with the middle to late stages of sporadic CJD, reflecting widespread, accelerated vacuolation, severe neuronal dropout, and profound reactive astrogliosis across the neocortex and subcortical gray matter. This extensive, diffuse tissue destruction fundamentally disrupts normal thalamocortical pacing networks, causing the remaining, structurally disconnected cortical networks to discharge in an autonomous, highly synchronized periodic fashion. In a clinical presentation of rapidly progressive dementia accompanied by myoclonus and ataxia, identifying this specific periodic sharp wave architecture provides exceptionally high diagnostic specificity for CJD. It serves as a vital neurophysiological surrogate marker that strongly corroborates advanced neuroimaging findings, such as cortical ribboning or hyperintensity within the basal ganglia, and positive cerebrospinal fluid biomarkers like RT-QuIC.